1 minute.
Oh, you're going to talk up there? Yeah. Oh, okay.
Yeah, can you put that up to, actually, if you can give me that one slide, that one slide up in the future lectures.
Yeah.
And then Gibbs this thing.
So you're done. Click here and then go to. Okay.
That's him. All right, so I'll take this.
Okay.
I'm
going to follow you.
15 seconds.
All right. Actually,
Good afternoon. I'd like to welcome everyone to this month's Metropolitan Trauma Advisory Committee Multidisciplinary Conference. We are teleconferencing to another sites and a bunch of individual locations as well. Welcome everyone there. At the end, we'll have some opportunities for questions. Please stand under the mic and speak loudly, or we can actually have the questions repeated towards the end as well. Today's discussion is going to be a little different. We're going to get back to this we haven't done at this conference for a long time. We're going to do a panel discussion on hemorrhagic pelvic fractures. Hemorrhagic pelvic fractures is a truly multidisciplinary area of injury, and unfortunately we see this and sometimes compartmentalized where not the entire team is not always present on initial evaluation. But I think it's really extremely important that this rapidly becomes a multidisciplinary decision-making and problem-solving with these complex and potentially life-threatening injuries. So for our discussion today, we have a diverse group to hopefully hit every major discipline as necessary. Dr. Cynthia Lauer is one of the trauma surgeons here at the Carolinas Medical Center. Dr. Gibbs is our emergency medicine representative. Dr. Kevin Phelps from the Department of Orthopedics, and Dr. James Chen from the Department of Interventional Radiology. And this will be moderated by one of the trauma surgeons, Dr. Huynh, who has moderated a number of panel discussions in the past. And I suspect this will be a challenging and obviously entertaining interaction. So just before we go on, the next two conferences over the next couple of months is Human Trafficking by Dr. Stacy Reynolds, Kendra Edwards, and Emma Evans. And the precise study will be discussed by Dr. Todd McKinney at Indiana University. But for today, in our hemorrhagic pelvic fracture, Dr. Huynh.
Thanks, Ron. We try to live up with the challenging part of it, the entertaining part of it. I'm going to rely on the audience to this. And as any of the panel discussion that you've seen in the past, the goal is to keep it as interactive as we can. So ask questions as we go along. We'll kind of have a couple cases depending on the time that we have. So feel free to just, raise your hand and then I'll point to you. So the objective for this conference is to learn about the clinical presentation of pelvic fractures. As Ron already alluded to, this is a typically life-threatening type of injuries. And as we go through the conference, you can see why and how it is that it requires a multi-specialty team to manage these patients. So we want to recognize the signs of pelvic fractures with the associated shock and implement effective measures to stabilize these patients. You want to be able to prioritize therapeutic adjuncts. And so as we go through the cases, we'll kind of go step by step, kind of following the algorithm to approach these patients that are unstable. And then I think Dr. Gibbs will give kind of an overview about the guideline, the management of these hemorrhagic pelvic fracture patients. And then preparing patients for definitive care. So the format is we'll start with an overview of pelvic fractures. Dr. Gibbs will present that initially, and then we'll go through the classifications of pelvic fractures, so understanding the anatomy, the disruption of the pelvic rings. Dr. Kevin Phelps will give that talk. And then we'll go through the case scenarios, which I think will be challenging and fun. And then the discussions. Again, we want to keep it as interactive as you guys can. So as Dr. Singh mentioned, pelvic fractures, they're not that common. They represent about 3% of all skeletal injuries from blunt trauma. They typically result from high-impact type of mechanisms: motor vehicle crash at high speed, motorcycle crash, fall from height. And they typically present with associated injuries. As you can see here, 15% of chest injuries associated with pelvic fractures. They have intra-abdominal type of injuries. 32% of them will present with these injuries as well. And then the other long bones, such as femurs or tib-fib type of fractures, they represent about 40%. So as you can see, because of these associated injuries, pelvic fracture patients, especially the unstable patients, present a diagnostic as well as a therapeutic challenge to us. The mortality, if we don't do it right, can be as high as 50%. They typically die from exsanguinating hemorrhage. That's the early type of death that we see. And then the later patients can die from multiple organ failure, and that's as a result of their hemorrhagic shock. The primary source of hemorrhage, typically in these patients, from the posterior venous plexus or bleeding from the cancellous bones. But 10 to 15% of these patients can be bleeding from their arterial source, the internal iliac arteries. And then as we go through the IR, interventional radiology, part of it you can see how that happens. And that means that the early role of angiographic embolization is paramount in the management of these patients. So with that as a background, I'm going to have Dr. Gibbs give an overview of this. As I was kind of going through the literature, I thought, who would be better to give a talk on this topic than the author himself, Dr. Gibbs? So let me switch.
Yeah, just see my slides. Appreciate the invitation to come speak and join this panel. And what I'm going to do is I'm going to tell you about a case that we had here a few years back. And I want you to imagine that Dr. Lauer and I are with the patient for the first 20 minutes, and we're the only physicians there. So all the residents are in conference, everybody else is operating. What do we need to do in the first 20 minutes with this patient? This is a real patient. He's walking home with headphones on, and he actually walks in front of a train. So yes, he did get hit by a train. It's a real case, and he comes in tachycardic, hypotensive, alert, with pelvic tenderness and abdominal tenderness, broken leg. Typical hit by a train guy, and here's his X-ray. So when you see this, basically there should be two thoughts soaring through your brain. When is the patient going to die? And secondly, who do I need to help me? So this, as alluded to, Dr. Singh started with that. This particular case, with this injury alone, is going to require a tremendous amount of help from a lot of people, and that's what we're going to be talking about this afternoon. So this is the patient's hemoglobin trend over 24 hours, and our patient got 12 units of packed red blood cells in addition to other factors. But despite that, you can see that major hemorrhage, ongoing blood loss, and persistent hypotension is a fact with a case like this. And really, so I have a very simple brain, and the way I think about this is the pelvis is the strongest structure in the body, so the strongest bony structure that we have. And therefore, when you disrupt this, the amount of force that's been delivered to the pelvis is extreme. So again, looking at that X-ray, want you to think about when is this patient going to bleed to death? And really, especially as Dr. Phelps is going to talk about, what happens here is that space that we've now created by opening the pelvis is going to be filled by red stuff. So our goal is to prevent that from happening. So major energy transfer, a lot of associated injuries, major risk for hemorrhage, and as Dr. Huynh alluded to, 50% mortality. Even in 2020, when this patient hits our door, they have a 50% chance of making it out of the hospital alive. So again, not much more than a broken bone, but a major red flag for multi-system injury and hemorrhage. You can see here that there are injuries close to the pelvis that are directly affected, the urethra, the bladder, the rectum, the vagina, and also there are associations with other very severe injuries to the brain, to the chest, to the aorta, and the abdomen. And abdominal injury really, I think, is probably the most important for us to detect quickly, and the question is, how can you do that? And ultrasound plays a major role, either ultrasound or diagnostic peritoneal tap, in deciding where do you go. So Dr. Lauer now is next to me, and we have a patient who's been hit by a train, and she's thinking to herself, do I need to go to the OR? Do I need to go to the angio suite? How can I get directed to go to the right place? And point-of-care ultrasound is very, very useful to help guide us. Stated differently, a patient with that X-ray who has a negative FAST in the ED, that patient most likely after resuscitation should go to interventional radiology. If the patient has a positive FAST, then she's going to be thinking about whether the patient needs a laparotomy and whether the spleen is injured, et cetera. As far as imaging, the indications for imaging in the trauma room are hemodynamics instability, altered mental status, and signs of pelvic trauma, so tenderness on compression, bruising, et cetera. These would be the indications for imaging. And I would say a major trap that we see occasionally is the desire to go to the CT scanner. So my plea is for us to be old-fashioned, make sure that we get plain films in the trauma room, because what you don't want to do is end up in the scanner with a patient with an unbound pelvis that's open like the one that I showed you that has not been treated in the emergency department. So making sure that we have adequate imaging is essential. As far as who doesn't need imaging, there's also very good evidence to show us that if patients are stable, alert, and they have no signs of pelvic trauma, no tenderness, that imaging is not required. So unstable patient, altered patient, signs of pelvic tenderness, imaging. If they lack those findings, then imaging can be bypassed. And as Dr. Phelps is going to talk about, we have injury patterns that even Mike Gibbs, a lowly emergency physician, needs to identify these injury patterns to know exactly what to do. So I can communicate with him, I can communicate with interventional radiology, and Dr. Lauer and I can make decisions about what happens next. So we'll review these patterns shortly. Guidelines that came out, the most recent Western trauma guidelines came out in 2016, and they talk about, again, avoidance of trauma-induced coagulopathy, aggressive use of compression devices, external fixators. We'll touch on REBOA a little bit, and then things that I will not do, preperitoneal packing and angiographic embolization. Remember that we want to avoid high doses of crystalloid for fear of creating dilutional coagulopathy and move rapidly to transfusion. And we know that we're all familiar with transfusion ratios of 1 to 1 to 1 that optimize the prevention of coagulopathy. We know that massive transfusion protocols actually decrease the need for transfusions overall and decrease mortality. We have this in place here, but this needs to be mobilized early, making sure that we have all the right products at the bedside. And this would be a very important case for the early administration of TXA, either in the field by MedCenter Air or on arrival in the emergency department. Again, 1 gram bolus and then 1 gram followed over an 8-hour period. And we mentioned compression devices, very, very important to reduce pelvic bleeding and to reduce pelvic volume that, again, Dr. Phelps will talk about. What this X-ray shows you is pre and post, before the application of a compression device and after the application of a compression device. And this maneuver alone can be life-saving for a patient who has major pelvic bleeding, and especially if the patient's being sent from another hospital, making sure that the pelvis is bound before the patient gets in the back of the ambulance. And we've had cases that have arrived here from another facility with X-rays that look like the X-ray on your left. So making sure that a binder is put in place. If we don't have a binder, simply putting a sheet around the pelvis and pulling it closed can be helpful. And the patient will scream and yell, but hopefully they'll send you a Christmas card thanking you for saving their life by putting the binder on there. And then what the conversation that Dr. Lauer and I will have is whether the application of a REBOA device in the ED or in the operating room can be beneficial. And the last thing that I'll say is that we know that to mobilize angiography in our hospital, the fifth busiest trauma center in the country. It takes several hours for us to have everything in place to do embolization. So I will be calling Dr. Chen very, very early on so he can mobilize his team and make sure that we have the right people here to provide that resuscitative strategy. So bottom line, one is recognizing when you see that open pelvis like that, that's a major cause of morbidity and mortality, up to 50%. Know that associated injuries are common. We all must collectively understand the classification system that Dr. Phelps will review with us next. And then from a resuscitative standpoint, aggressive resuscitation, using your FAST to identify other associated intra-abdominal injuries, preventing trauma-induced coagulopathy, early pelvic stabilization, and then using REBOA and angiography as an adjunct can be quite helpful during the first 30 minutes.
So thank you, Dr. Gibbs. Next, I'm going to have Dr. Phelps present the classification of pelvic fractures.
So again, thanks for having me. I'm Kevin Phelps. I'm one of the orthopedic traumatologists here at Atrium. We're going to talk very briefly about the classification and initial management of pelvic ring injuries. Dr. Gibbs gave a really nice overview and touched on some of the things that I'm going to touch on here also. So our objectives are to go over the general classification of pelvic fractures, not really get into all the nitty-gritty details that we as orthopedic trauma surgeons worry about, but more as just in general, how do you place pelvic fractures into different groups, and which ones should you worry about, and also what to do when these patients present to your ED. For the classification that we're going to be talking about, it's mainly based on injury mechanism and the force vectors that cause the actual pelvis injury itself. And these are divided into three broad categories. I mean, the first is lateral compression type injuries that typically occur when the pelvis gets hit from the side. The second is an anterior posterior compression injury when the pelvis takes an anteriorly directed force. And the third and last one is a vertical shear type injury. So for lateral compression, these usually happen when people are riding in either the driver's or the passenger seat of a vehicle and they get T-boned. The side of the pelvis takes a force vector that ends up breaking the rami in the front and also causing a crush injury to the sacrum in the back. And a lot of times, as you can see here, this will oftentimes reduce the pelvic volume. Now, that doesn't mean that these are going to be less likely to bleed or necessarily that you don't have to worry about hemorrhage for these, because these can also have significant bleeding effects as well. The anterior posterior compression injury or the open book pelvis is the one we worry about the most when it comes to bleeding. This is the one with the higher mortality rate. This usually happens with an anteriorly directed force, such as somebody riding a motorcycle and gets hit head on and their pelvis impacts the gas tank on the motorcycle. Usually disrupts the symphysis, usually disrupts the ligaments that Dr. Gibbs touched on just a few minutes ago. And the last one that's a little bit more uncommon is the vertical shear type injury. This usually happens with a fall from height, or a lot of times we see these in jumpers. The force is usually either directed from the ischium cranially or up through the extremity. And these can also be devastating for patients and have a higher risk of vascular injury. The ones we really want to focus on and the ones you want to be aware of are people that present like this. And this is what we call volume expanding pelvic ring injury. And this is a patient that Dr. Gibbs was referring to, that this patient's could die in any minute. So this patient initially presented was awake and talking in the emergency department, and they can go from that to dead on the table within a minute or two. So it's really important to understand the devastating nature of these injuries. And when you think back to geometry class, so the pelvis has been described in terms of its geometry in a couple different ways. I think the best way to think about it is somewhere as a combination between a sphere and a cylinder. And the thing to really focus on is that as these shapes get bigger with their radius, that the volume increases exponentially based on these equations that we learned back in high school. And so we want to think about ways to reduce the volume of the pelvis as quick as possible, because as you increase the volume, it increases the space for bleeding within the pelvis, both from arterial and venous sources. So the thing we want to think about doing is wrapping up the pelvis, and you can do this multiple different ways. You can use a sheet, you can use a binder like Dr. Gibbs showed earlier. This is just a method of using a sheet, and you really, whatever you use to wrap the pelvis, you want it centered over the greater trochanters. This is a method that just takes two people. You basically just fold a sheet into thirds, wrap it around the pelvis, pull it tight, gathers up the pelvis, and then you use the clamps, as you see on the right picture, to hold it in place. It's actually very common for end up in a situation like this where either patients come in from an outside facility or from the scene, or there's a lot going on in the emergency department. You're trying to get lines, and all of a sudden you have a pelvic binder on, and people think it's in a good location, and it looks like this picture here on the left. And you can see that it's also been cut into, which has decreased some of its effectiveness, and you can also see the X-ray there on the right with the binder way above the pelvic ring. This is something that you can do if you use a sheet, and so if you need to get access, you can always cut working portals within the sheet in order to access the femoral artery, femoral vein, whenever you need to do. And we can also do this as orthopedic surgeons to put external fixation on the pelvis as well. I think it's important when you wrap the pelvis up in these people and reduce the pelvis to try to avoid taking the binder off at all costs until these patients are totally stabilized, or until you basically discuss with the orthopedic trauma surgeon that's going to be taking care of the patient. Try to leave this on once it goes on and not remove it. It's also important to note that a lot of times these people, and we kind of forget about this sometimes, and although it's rare, sometimes these people can have open injuries, and these are a little bit hard to pick up on sometimes when people are a little bit more obese. These can hide in groin creases, but it's always important to do a thorough exam and make sure you identify these injuries and pack them with Curlex. Don't use laps or gauze to pack these, because nobody knows how many gauze you put in the wounds other than you, and a lot of times you don't even know. You just pack them in, and so if you use Curlex, that can be removed as one unit, and it's better for the patient. And so when we think about the volume of the pelvis, we talked about how it's a combination of a sphere and a cylinder. So what we want to think about doing is closing down the volume of the pelvis, and you can see how it changes as we put the binder on that's centered around the greater trochanters, and it reduces the volume of the pelvis and could potentially save this patient's life, and decreases the space available for blood to collect in and around the pelvis. And that's just the X-ray showing the binder in a good location right around the greater trochanters. So the bottom line is that you want to always be aware of the volume expanding pelvic ring injuries. These are the bad actors. You always want to pack open wounds with Curlex, and make sure you wrap up the pelvis as soon as you recognize it on an X-ray, which should be your initial mode of evaluation of the pelvis. Thank you.
Thanks, Kevin. All right. So now to the fun part. So far we've talked about how these patients present, how they can die in the emergency department if we don't do things appropriately and expeditiously. We talk about the classification of pelvic fractures and the energy vectors that create them. So now let's go through these case scenarios, and again, please keep it interactive as much as we can. And these are, I picked a couple more recent cases to illustrate the point. So this is a 53-year-old male who fell from 2-story height. At the scene, the paramedics report that his heart rate is about 100, his blood pressure is 100/60, his Glasgow Coma scale scores is 13. There was question of whether he lost consciousness or not. Of note, Dr. Gibbs, for you, this patient has atrial fibrillation. He is on Xarelto.
Of course he is.
Of course he is. And that's one of the new anticoagulants. He was called out because of those vital signs. He was called out initially as an adult trauma code 2. And for the audience who may not be so familiar, at CMC Maine, number 1, adult trauma code 1 is the highest priority. Those are the unstable patients. And some of the physiologic criteria that go into sort of coding these patients out. This patient was coded out as an adult trauma code 2 because his blood pressure seems okay, heart rate low 100s. On arrival to the ED, he was diaphoretic. His GCS remained at 13. He's breathing at about 24 times per minute or so. His O2 saturations are 94% on high flow oxygen. You can see his heart rate's there, his vital status there, and then his initial hemoglobin is 13.6. Pretty reassuring, right? Pretty good.
No.
Okay. His lactate is 11. He was intoxicated. So, Dr. Gibbs, your patient in the ED, what would you like to do?
So X-rays as per usual, like we talked about. I'm assuming that he does have a pelvic injury.
Oh, maybe.
So resuscitation first, right? And which means large bore IVs, which means we're going to be thinking about red stuff pretty early. Remember, his shock index is 1, which means he is in shock, even though his blood pressure is 100/60. The fact that he's on Xarelto is important, and he's altered, so airway management may be in his future. So there's a lot of things that we're going to be thinking about with a lactate of 11. I would say, again, Dr. Lauer and I are in the room for the first 20 minutes. Large bore IVs, mobilize an MTP pack. He's likely bleeding, so he's going to get TXA now. And also, we can talk about this in a minute, he needs to be reversed. You know, as soon as there's any inkling of where he's bleeding, he would need to be reversed. And for Xarelto, it would be 4-factor PCC, 50 units per kilogram, full reversal for him. So what else can you tell me?
So that's a lot of information to take in, right? I'm keeping it simple-minded as a trauma surgeon. I'm thinking airway, I'm thinking, okay, it's got automental status, and I gotta take a look and reassess his airway.
And as far as diagnostics, I think we would want a FAST, a chest X-ray, and a pelvis. That would be helpful to have those 3 elements.
All right. You asked for it. There is his chest X-ray, and there is his pelvic X-ray. Can you tell the audience what you see and what would you like to do with this patient?
So not in the, I mean, the mediastinum is not fabulous, but not in the chest, and looks like a fracture through the right iliac wing. Pelvis is not wide open, but again, just with that injury alone, that's a lot of energy transfer. So resuscitation begins.
All right. Mm-hmm.
And then probably, you know, Dr. Phelps we can debate the value of a binder. I would say probably not as imperative compared to the X-rays that he showed us a few minutes ago, where the pelvis looks like this.
All right. Any questions from the audience so far? This is an adult trauma code too, so if you were Dr. Jacobs, he'd be like, okay, let me grab a bite to eat before I head down to the ED. I just saw him. He just walked in. There he is.
I mean,
but since this is Dr. Lauer, she's running down to the ED, and she's thinking, okay, this is the chest X-ray I got, and that's the pelvic X-ray I have. The FAST is equivocal. They couldn't see the pelvic view very well, but the other quadrants appeared negative. What kind of fluids do you want to use, and how do you want to kind of continue your resuscitation here, Dr. Lauer?
So I would want to call for blood early. So we've activated the massive transfusion protocol. We're upgrading this trauma to a code 1 just to mobilize resources and communicate with the rest of the facility. I would go ahead, and if the patient still has, tachycardic and relatively hypotensive with a shock index of greater than 1, I would go ahead and give what blood I had in the ED as well as plasma, and I'd probably go ahead and order PCC for reversal rapidly of his anticoagulation.
So if you've heard, 2 of our expert panelists wanted blood and blood products early. Just to clarify, at Maine, we call a massive transfusion protocol 6 units of Paxil, 6 units of fresh frozen plasma, and 1 apheresis unit of platelets, which used to be called a 10-pack of platelet. So that's our MTP, or massive transfusion protocol. Wait for it. So this patient in the ED got 2 units of Paxil, 2 of FFP, and Dr. Gibbs ordered the 4-factor prothrombin complex concentrate, or K-Centra. So 4 factors being replaced as well because of the Xarelto. After those transfusions, you can see his vital signs there. His blood pressure is now 90/60. His heart rate is 130, and his GCS of 7. Dr. Gibbs, back to you. Now what?
So he's in trouble. He's in deep trouble, and
Yes, we are.
And now we're thinking about intubation, which is going to be risky. Needs to be done, but remember that work done by Alan Heffner, one of our intensivists here, looking at peri-intubation hypotension. The biggest predictor of peri-intubation hypotension is a shock index of greater than 0.8 that had an odds ratio of 55 for peri-intubation hypotension. So this patient will drop his pressure after intubation and positive pressure ventilation. And probably the things that we can turn to try to mitigate that, I would say, again, Dr. Lauer and I at the bedside, we're going to pressure back in as much product as we can in the couple of minutes that we're going to prepare to intubate him. We'll use ketamine preferentially, and probably the other thing that needs to be paid very close attention to is how he gets ventilated after he's intubated, because if we hyperventilate this man in any fashion, he will die immediately because his vital signs are so compromised. So I would say push forward with aggressive continued resuscitation. Intubate him now, but I'm going to be super nervous about it, about intubating him for the reasons I mentioned.
Okay. All right. So we're ordering more blood products for this patient.
And the other thing I would do is I would repeat his fast right now and see if he's blossoming and whether he has, you know, whether we have a better sense of whether he needs a laparotomy or not.
Okay. Dr. Phelps, what do you think about this pelvic in terms of binding or external compression to it?
Yeah, it doesn't look like he has an incredibly volume expanding pelvic ring injury. It looks like he has a combined injury that's really an acetabular fracture on the right side combined with what is probably a vertically displaced sacral fracture on the same side. And so the binder or a sheet in at this stage is probably not going to give you as much benefit as if the volume of his pelvis was increased more than it currently is. I think probably what we would do in this situation is probably put him in traction to the right leg as soon as he was stabilized from an emergency perspective. Do I think a sheet would be wrong in this scenario? No, I don't. There are people that worry about putting sheets and binders on people that may not need them or that have even lateral compression pelvic ring injuries and them causing damage. When you think about the force that went through this guy's pelvis, putting a sheet on it's probably not going to do anything harmful. But I don't think it's going to help all that much from a resuscitative standpoint.
Steve, any comments about that? Do you agree? Disagree? Trying to create some controversy here.
So, I mean, you want to immobilize the bones, right? So that is he bleeding from the arteries in his pelvis, or is he bleeding from all bony surfaces and venous bleeding? And you hope he forms clot and stops bleeding. Traction, I think, probably shouldn't wait until after you get resuscitated, that right away, and then a binder or sheet would not hurt. It would give you some stability. I don't think it'll close the volume down, but it keeps his pelvis from moving around. It would not be harmful to put something like that on as well. Full hard and aperture is a really good and effective binder or sheet. It's not going to be in the way of it.
So for the audience at the remote site, Dr. Steve Sims is one of our senior trauma orthopedists, and was trying to get him to disagree with Dr. Phelps, but they're pretty consistent in terms of, okay, the binder may or may not help, probably not, but it wouldn't hurt. So applying a binder on this is sort of plus or minus, but I think we all agree so far that ABCs, airway, breathing, and then mostly primarily the focus is on the resuscitation and blood products. Dr. Singh, you have a question.
Yeah, there are a lot of moving parts here, and I think it's the trying to keep every aspect of the resuscitation moving so you don't particularly miss anything. I think a really important point that Dr. Gibbs brought up was we had a relatively equivocal fast exam that was continuing to deteriorate. Redoing that study is really critically important because that subcapsular splenic injury may not be subcapsular anymore. This may require, so I think that's really important to keep up on it. The other aspect would be the ongoing resuscitation. But I think as in the emergency department and even when we show up, I think the way the physiology presents from the very beginning, I think the call to Dr. Chen should occur at the beginning of the resuscitation. at the beginning of the evaluation, at least to notify him, because it takes 10 minutes for him to answer the phone, let's do another 10-minute delay. And that conversation can occur along the way, and there are times where we call them and then blow them off later. I think we kind of apologize for that, but at the same time, I think we're looking at a 10-minute delay in a phone call could actually resolve another 20-minute delay in actually getting the procedure. So as we're trying to coordinate the ongoing resuscitation, it's important to get them involved. Even if that involves going to the OR, it's not uncommon we go to the OR, then go to interventional radiologists. They're kind of waiting for us to be in the case. But I think the communication, notification are always important.
Okay, so far I think we all agree that we'll use more blood products for resuscitation. After the additional 2 units of Paxos and FFP, now his vitals are, as shown there, seem to improve now after 4 units of blood. And we talked about binder probably doesn't hurt to apply, but may or may not be that effective. Traction may be in a delay fashion, maybe when the patient gets to the ICU, if he can get there. And then CT scan. Dr. Cunningham, did you want to ask?
I had a question. You're all talking about resuscitation. I'm assuming a typical trauma patient, let's say we got lucky, we have 2 large bore IVs in his upper extremities were adequate to give resuscitation for 1 here. So we'll leave the central venous line out of the equation for now, the resus line. But our guideline would stipulate to this patient that they continue hypertension, and at the point you're 90 over 60, it's a femoral arterial line. How do you balance need for resuscitation, whether it be with a venous line for access, arterial line for monitoring for interventions with your binder that may or may not make a difference in this case, like years down the line. But really, how do you answer what your ideal access monitoring is for this patient? Kind of at this point, because I know it might change as you go forward. Clearly, our interventionalists have a different preference in terms of access to our own disciplines, our own biases. What would your ideal access monitoring patients?
So the question is access for this patient. Dr.
Lots of access.
Dr. Lauer?
But I would say
elaborate
in the ED, I already know what I'm going to do, so I don't need an arterial line. I know what he needs. I know what I'm going to do. Even if his vital signs improve, I'm still really profoundly worried that he's going to bleed to death. So that helps me a little bit less than it may help you in the ICU, or maybe when the patient leaves the ED and is in a more austere environment. But I'm thinking about saving his groin for Reboa. That may be the other question, and that Dr. Lauer may help me with.
So I would say if you had 2 large bore peripherals that you were able to effectively transfuse rapidly, that would be adequate. I would have a low threshold for putting in an introducer sheath for more rapid, high volume transfusion. I certainly think having a low threshold to put in a femoral arterial line is warranted in this scenario, and that is for multiple reasons. I think you can put in an arterial line in the femoral artery that will enable you to rapidly change that out to a Reboa should that be needed. It also gets that access so the interventional radiologist can use that down the line if they have to. So I think the point about an early arterial line in the femoral location in this injury is pretty important, as that allows you kind of multiple directions down your path of interventions.
So, Dr. I was going to ask Dr. Chen. So I guess before you answer the question, I have two questions for you. One is, as Dr. Singh was kind of alluding to, when would you like to be contacted about the patient, and then comments about the arterial access? Because they want to mess up your line here. They want to mess up your line.
So I think, that every team's going to have a very kind of different perspective on this, because we're so focused on our own piece of it. Orthos, and we often have it where they're calling us to embolize, and they're fixating some fracture down there. And obviously, every team is really focused on fixing their own piece of it. If you're in an environment like CMC Maine where you do have access to, we're really on call. One of the main reasons is for level 1 traumas here. And so we alluded to the fact it can take a while for us to get in. I apologize for some of my senior partners if that's happened in the past, but really we're usually accessible within half an hour from the time of the phone call, we'll be here in person. Within 45 minutes, the patient will be on the table with our catheters inside. We'll be done with the embolization probably within an hour or so. So it's actually fairly expeditious. Patients can also get sent through that CT scanner and get a CTA, and you know exactly where they're bleeding from within, it's a fairly fast process nowadays that we can do that. I'll say from the standpoint of access, the one concern that we do have if people are accessing arterially, if there's it's I imagine a very frenetic environment in there. You have a lot of people surrounding the patient. You may have trainees in there. If you dissect the artery, if there's some complication with one of the accesses, now we've lost our path in. We can certainly establish arterial access under ultrasound very quickly for you in the IR suite. Should you need some sort of arterial access left there for you, we'd be happy to do that. And oftentimes, if the patient's coagulopathic, we will leave our sheath in place so that you don't end up with access site hematoma. And the last thing about access, with binders, we do have ways of accessing the radial artery now. We typically use this for elective procedures only because the hemostasis process is a little bit more involved than ephemeral, where, those will leave the IR suite with nothing in place. But there are centers that do predominantly radial access where it's a great solution for trauma because we can stay away from the pelvis entirely. We go through the left radial artery and are able to do the whole intervention from there. But it does require some training on the trauma staff afterwards to remove the hemostasis device, which is just a little band around the radial artery. So I think, if they're tanking very quickly and you suspect there's an arterial bleed, the faster we can shut that bleed down. I would think that, you can pump as much stuff as you want into that patient, but if they're losing it straight into the pelvis, we can temporize it with a binder and hope that tamponades, but I think the faster you can get a team in to close down the bleed, the better the outcome. So.
Specifically related to the binders, I think one of our fears anytime these patients go down to the IR suite is that the binder is directly overlying your access point, and that the only solution is to remove the binder in order to get access. And I think solutions for that are twofold. That one would be if we use sheets, we can obviously cut the access points in the sheets, like the pictures that I showed in the slides that I had. I think it's a very effective way to do it because you don't have to adjust the compression from the sheet at all. I mean, you just literally cut an access point. You can use I-band or whatever you need to do over the top of the sheet. The other thing is if you either have a separate binder, so you have two binders, or you can take the binder that's on and put it down on the thighs and really cinch it up tightly on the thighs. That can also provide some internal rotation to the hemipelvis on both sides. Not as good as having it over the trochanters, but if you have it over the thighs, at least it's doing something. And you can also put another binder up around the iliac crest, and if you have one around the thighs and the iliac crest, then you should have your access points to your femoral artery.
Okay.
One surgical team that's not here with us is often involved in this as well, but you also often have urethral injury and urologies involved for that. So we'll often be called for these pelvic embolizations where, halfway through the procedure, they're like, oh, we maybe need a suprapubic catheter. Actually, this patient's had urethral injuries. So in terms of the binder, we sometimes are, now we have to open up the binder even more to have access to that. I think the good thing about embolization, if they're, losing blood predominantly from an arterial source and we can close it, then opening the binder in some of those cases, the embolization at that point will be something that's 10, 15 minutes away as long as they're stable enough. I think cutting the holes is a great solution as well, but oftentimes they come with those binders that aren't sheets. And so we're left with a situation where we have to open it, at least temporarily, to do our embolization before we close it again. So from a practical standpoint, the sheets might actually be better for us.
All right, back to Dr. Lauer. Where do we go from here? Do you think it's looking at those finals, are we okay to go to a CT scan, or should we go to the operating room, or where would you like to?
I think repeating my fast, and if I don't have great windows on my fast, I'm not confident on it, I would have a low threshold to do a DPA in order to evaluate the abdomen further. I would also want to have them demonstrate some stability in the trauma bay before rolling out to CT. So if I had a great fast or a negative DPA and stable vital signs, I would feel better about rolling to CT.
Okay. So for the audience, you've heard about DPT, which is a diagnostic peritoneal tap. That's when we just put the needle in there, we aspirate. Same thing with the aspirate. DPA, diagnostic peritoneal aspirate. And then the lavage we don't do so much anymore, because really the goal there is to see if there's blood in the abdomen or not. The repeat fast was the same. The pelvic view was equivocal, but the other views were negative. So this patient went to the CT scanner. And as you can see, Dr. Chen, would you like to help us? I'm sorry, for sake of time, I just kind of took the sort of pertinent views.
Sure. I mean, you have these multiple axial images. The image on the bottom right shows large area of contrast extravasation, kind of posteriorly near where the sacrum is along the musculature there. And then looking at the other images, you can see some of the resultant hematoma as well, extending along the psoas and iliacus on that side.
Okay. And I can tell you that the liver and the spleen appear intact on the upper cut, so I didn't show that. So now, with that in mind, you think it's okay to go to IR at this point, Dr. Lauer, Dr. Gibbs? Any comments? We repeat the fast, and that was the same. It's still equivocal, but nothing, no big stripes.
If the patient still is not crashing, I would probably direct them to IR. I think if the patient was very unstable, number one, I have two kind of concerns with a bad pelvis that's actively hemorrhaging. Number one, it's a little more difficult to resuscitate in IR just because that's not our usual space for resuscitation, and I would much rather be in the operating room for that very, very unstable patient. And then number two, I can't get a patient to IR. I know that my colleague thinks that we can easily get them to IR in a timely fashion, but at least nationally and here it sometimes can be difficult. So if I can get them to IR in 20 to 30 minutes, then that's great. But if it's going to take a long period of time, I think nationally the average is more like 90 minutes to get a patient to IR versus to the OR it would be 60 minutes. So kind of the direction of OR for resuscitation and preperitoneal packing versus IR depending on the patient's stability, I think, and timing of availability.
Okay.
So Dr. Jacobs has his hand over his face, and David, I remember we looked at the data from last year, 2019, time to IR from the ED, from arrival, and I'm pretty sure that, and by the way, this is a collective responsibility, so it starts with all of us, but I think if I can recall, our time to IR was between 3 and 4 hours from door to IR.
Yeah, that number's gotten better with our most recent people report, but it's much higher than you would expect.
Yes, when is the call happening to IR? It's kind of a strange number to, we often get calls about these in the middle of the night for 2, 3 a.m. and there's no way someone's taking 2 to 3 hours to get ready before coming in. So I understand from the door you guys are doing a lot to get that ready, but I think we can get IR in here in a fairly expeditious manner, and whether that changes.
Yeah, and I'll say it again. There are collective delays. Like patients always spend more time in the ED than we would like. They always spend more time getting transported to location X, Y, and Z. So I think in aggregate, that's what I took away from that number, is we can do a better job at every phase of the resuscitation and the patient's care to get to them to where they need to be.
Okay, so Dr. Chen, patients now you're in the IR suite. What's your approach, and how do you attack it?
So, one of the first questions is, are there any other open injuries, musculoskeletal injuries in either pelvic area? If they have an open wound on the right, for instance, we typically preferentially will go for the right just because of the setup of our rooms, but we can access from the left common femoral artery as well. The radial artery access, again, is something newer that we can potentially do. It's not something that we've done up to this point because of the hemostasis issues being different and requiring help from other teams to take care of. Once we're in there, regardless of which access, we will put a catheter into, you could typically put a catheter up into the abdominal aorta and do kind of a distal abdominal aortic pelvic run, so you can see both internal iliacs at that point, have a sense of, and from your CT, for instance, this time we need to get to the right internal iliac to shoot that first because that's where the bleeding is actively on the CT. Once we identify the bleed, presuming it's still present as we see it on the CTA, the coil versus gel foam embolization, it really depends on if you see a large site of extravasation where you feel gel foam is The way that we inject it, we make it into sort of a slurry that we can inject as almost a liquid embolic. If there's a large vessel injury where contrast is just pouring out of that site, the gel foam may also pour out of that site into the pelvis and not give you adequate hemostasis. If it's a relatively smaller artery, more distally, where it's going to be difficult to get our catheters out there, if there's multiple sites distally that are bleeding, then gel foam often is a very excellent solution. It's a temporary agent that will go away within 2 to 3 weeks, which is perfect for this sort of scenario where the patient will hopefully have healed and then they won't have a permanent occlusion there, whereas the coil stays there forever. So, and then I guess they gel foam embolized was the last description there.
So that's what the patient had. Yes, Dr. Sims.
Yes.
The question is, when we looked at patients that got embolizations, about 9 or 10% of patients had a decrease in their renal function of at least 50%. And whether that's because they got a big injury, or hypertensive, and may not have been a healthy patient to start with, or whether it's because of a contrast load, or all of those things, it's probably a combination. The question was, when I looked at the amount of contrast that they got, it was in the range of 100 to 150 cc's of contrast. Milligrams. It ended up being what would be considered a toxic dose, I think, in most people. If you could give me some, this was a while back.
Sure. So
Information on how much contrast they typically get, how selective you try to be with
Sure.
and the other complication, of course, is the less selective embolization is always more the
Sure. Well, two things. One, the literature and the science of contrast-induced nephropathy has really evolved dramatically, and I think it's very challenging because it is the patients who are sick that we're scanning as well, and it's always been difficult to separate the confounding factors with, is it the patient's kidney function decreasing for other reasons, or is it really exacerbated by the contrast? I think we're still, and I think the literature now shown from not the trauma setting necessarily, but from generally getting CTs, is that we don't think contrast is really contributing as much to this as we've believed so in the past. From the standpoint of minimizing contrast dose, we just sent them through a CTA. Typically, we're using weight-based protocols now, which have reduced the volumes, but previously they would receive 120 ml of contrast by default going through the CT. So we're already at that level of contrast, so we're going to take them to the IR suite and give them more. The more selective we can be with our angiography, the less contrast we'll use. So with this patient, for instance, I might skip the aortogram entirely and just go and select the internal iliac arteries. At that point, we're injecting, loads of maybe 8 cc's of contrast to be able to see where the bleeding is. Probably, between 6 to 12 more to be able to select the branches that are bleeding. If we coil embolize something, we're trying to select out a more distal branch, we may need additional arteriographic runs, which adds a slight bit more, but still, I think 120 cc's is a lot. I'd say a lot more than we would typically need for this. Maybe something more on the order of 60 cc's now we can get away with, and we also dilute our contrast now. So, many of these patients, if they're relatively younger and healthier to begin with, they're not obese, we can see the contrast pretty well diluted to 50%. So that gives us twice as much volume as we even would be using before. And if we're just going to gel foam embolize something more proximally, we do try to avoid the superior gluteal artery to avoid some of the gluteal claudication and things that you can get if you just randomly close off the entire internal iliac artery distribution. But that also allows us to get in there, take relatively few pictures, embolize, and get out with as little contrast dose as we can.
I know it's a continuous factor, but what dose, for say a normal healthy person would really worry you it's causing a problem?
It's causing a problem. I think occasionally we have to re-inject patients twice for the same CT if there was some issue, and if your kidney function is normal, you should be able to tolerate that dose of 200 mLs of contrast should be fine. For other types of embolizations like uterine artery embolization we do for fibroid patients, we sometimes do have to go to higher doses, and those women typically do very well. So, but this is totally, when the patient's this sick and in shock, it is a very different situation.
Okay. All right, very good. So he underwent successful embolization. Dr. Phelps, your approach to this?
Yeah, so this is a combined injury with a right-sided acetabular fracture and also an associated pelvic ring injury. This is not and unfortunately, this is not one where there's a lot we could do acutely, other than what we've already mentioned in regards to stabilizing his pelvis, which would include traction and plus or minus a binder or a sheet. This is not a situation where we would do external fixation. We don't typically do those for acetabular fractures. As far as when to perform external fixation, it's actually getting more and more rare from our perspective to do acute external fixation on these patients, and it would be very specific scenarios where we would do that, because most of the time these patients are getting bandaged up with either a binder or a sheet, and then proceeding to the operating room within 24 to 48 hours in a lot of ideal situations in order to get fixed. Specific situations for external fixation would be if a patient's in the operating room is in extremis and you're basically trying to save the patient's life and they cannot go down to the interventional radiology suite and you have to do some sort of pelvic packing. I think the important thing with when you mention pelvic packing, like Dr. Lauer did, is you really need to have a stable pelvis to pack into. And so if you have an unstable pelvic ring, if the back of the pelvic ring is unstable, if the front's unstable, and you just pack, the pelvis is just going to keep expanding. And so you really need an external fixator on the front and even sometimes acute fixation in the back in order to get a stable pelvis to pack against. Internal fixation for this is going to be a very extensive all-day type operation, and so this patient's not going to go to the OR typically until they're very stable on the floor, have been stable for a day or two, and are otherwise doing very, very well clinically.
All right. So as you said, this patient went to the OR about 48 hours after his initial presentation. And that's your fancy work there, Dr. Phelps. Can you describe to the audience what was done?
I actually remember this guy very well. We basically have to make a big incision on the front of his belly that goes from his symphysis all the way around his iliac crest, and fix the hip socket on the right side, and then basically make a decision whether or not to do a more extensive approach versus try to do closed methods to treat the posterior aspect of his ring, which is a right side displaced sacral fracture and associated rami fractures in the front. And so this guy was an all-day case and had not an insignificant amount of blood loss. I mean, that's the thing you got to remember in these people is the blood loss for this case can range anywhere from 500 if everything goes perfectly to 2 to 3 liters if the patient's oozing. So and it's sometimes hard to predict. So you got to make sure these patients are stable when you take them to the operating room. But I think getting his pelvis stabilized was obviously good for him, and also helps with the resuscitative efforts moving forward. And I actually just saw this guy back in clinic not too long ago, and he's doing pretty well.
Yeah, patient ended up doing really well on this. And one thing I didn't ask Dr. Gibbs, but the patient did receive TXA in the ED before he left the ED. So he got a bolus of TXA down there. So, all right. Any other questions about this case? Dr. Jacobs.
Yeah, I'd like to put Dr. Singh on the hot seat and ask him about the role of VHA filtration. So you stop this guy's anticoagulation. He's going to be anticoagulated 4 or 5 days, or if he goes back and forth, he's going to be off of his Xarelto. So is this patient going to filter or not?
Yeah, I think 5 years ago the answer would be yes. I think even today we are still much more aggressive with anticoagulant prophylaxis, although still not 100%. I think in this particular setting, the answer would be no. He is still what I would consider high risk, and I think a screening duplex is still not an unreasonable thing to do in about the first 40 to 72 hours as well. But I think as an empiric quote prophylactic filter without a VTE event, the answer would be no. When you restart his Xarelto. Well, the Xarelto years are. Oh, sorry. No, go ahead. Well, the Xarelto in this setting wasn't for a VT event, it was for atrial fibrillation, so you're looking at a couple percentage per year, so this guy can stay off the Xarelto for fairly significant period. Yes, perfect. Oh, awesome. Well, but, life sucks.
Okay. Well, in the interest of time, we're not going to have time to go over the second case, but I'll just show it quickly. 50-year-old female pedestrian. Those are the vital signs initially, otherwise healthy. The patient actually was coded as a trauma alert. in the ED. That's a GCS score, vital signs, lactate of 2, base deficit of 4. She had a chest X-ray and a pelvic X-ray. I don't think we have time to go over the images, but I'll just describe the case. She went to CT scan. She had a grade 3 splenic laceration. She returned to the ED, and that's where trauma was consulted for her injuries. So she had a pelvic fractures, a grade 3 splenic lacerations. In the ED, she became unstable, got blood, got the ortho consult, went to IR for gel foam embolization of the left internal iliac and splenic embolization as well. She was placed in a left femoral traction for the fracture pattern, and she underwent Dr. Phelps. This is your case as well. It's a lot of metals in there.
A lot of metal.
A lot of metal. She actually ended up doing well as well, and she, I believe, was discharged last week from the trauma service to home. So, in summary, as you can see throughout the conference, the pelvic fractures results from high energy mechanisms. We talked about the classification of pelvic fractures being AP compression, lateral compression, and vertical shear. The PROM recognition and aggressive resuscitation can improve outcomes and the morbidity and mortalities for these patients. The early emphasis of use of blood products, massive transfusion protocol being a 6 of PAC cells, 6 of FFP, and 1 apheresis units of platelets. Stabilization of the disrupted pelvic ring can help reduce that volume that Dr. Phelps talked about. And then expeditious angiographic embolization for arterial injuries in these patients. As you can see, this is really truly one of those multi-specialty care type of injuries. It takes the team effort to stabilize and to take care of these patients. And then there's, a systematic approach in the care of these patients can help reduce their mortality. So, any final comments from the panel? Any final thoughts, questions? Dr. Jacobs.
Yeah, I know I didn't get to the phone call so late about the PD.
Right.
And I know you didn't intention to do this, but we completely skipped over the physical exam. I know it's an old school thing.
It's old school. We don't do that anymore, Dr. Jacobs.
Particularly in pelvic fractures, particularly in female, physical exam is important. Normally you're going to figure out that you're getting with an open pelvic fracture that has an entirely different algorithm. So, and I'm not sure whether Dr. Phelps wants to comment on this, but everybody, when you walk in the room and you see that film, everybody wants to see what an unstable pelvis fracture looks like. So you got environmental services coming in, vascular care, everybody's mashing on the pelvis. And I do think it's important to make sure that you get one good exam, stabilize the pelvis, then all these other exams that end up happening.
Points well taken, but I think Dr. Gibbs did touch on the physical exam part of it at the early part of the presentation that you missed. Dr. Ross? Right.
I had a question about the pelvic flanker. When do you take it down? Do you down after mobilization? Do you leave it for 4 hours?
So from my perspective, so all pelvic ring injuries are not equal. And so if it's just a symphyseal widening, if it's like an APC2 with 3 or 4 centimeters of widening anteriorly that we're going to fix, if the patient's otherwise stable, a lot of times we'll loosen the binder. If it's a patient like I showed, where if you open the binder or you take the sheet off, that their pelvis like expands an incredible amount, then I'm probably going to be more inclined to leave it on. Again, if we can't transition these people out of some sort of external compression device like a binder or a sheet within 24 to 48 hours, we're going to think about doing something less invasive, like maybe placing an external fixator until they can more definitively get to the operating room. Or we'll tag on to one of your guys' procedure and do something to try to get them out of that. But it really depends on their clinical status and how they're doing in the ICU.
Okay, I know we're running over time. Any closing comments, Dr. Singh? Otherwise, I want to thank my panel, Dr. Lauer, Dr. Phelps, and Dr. Gibbs, and Dr. Chen, who had to leave to do procedures. and the audience for participating. Thank you very much, and we'll see you next month.